We have been asked to talk about return to play after overuse injuries, and we've decided that we will try to give 2 clinical cases to see how it can be done and how we have to think differently with different patients. So hopefully this talk will affect your overuse injury return to play practice as well. And the aim of this talk is to demonstrate 2 concrete cases of return to play decision making for patients with overuse injuries. Case number 1, which I will do, is the adolescent athlete that all of you and I see in the clinic from day to day. And the second one is a young elite athlete. So this girl actually came into my office a few weeks ago, 13 years old, playing basketball 6 hours every week, plus weekend matches. And that's one of the main points. Maybe it's not weekend match, it's matches. She has anterior knee pain since May this year, and she has seen a doctor who noted that with ultrasound she had neovascularization at her apex patella. So I guess most of you already have a tentative diagnosis in your head. And what should we do? Radial shockwave therapy, injection therapy, eccentric strength training, or maybe something else. So we'll start here with kids and adolescents. They are different from adults. They have physis. We have the distal femoral physis here in the femur. We have the proximal tibial physis, and then we have the apophysis, which is one here at the tibial tubercle, and there's also apophysis here in the patella, which makes kids and adolescents different from adults, and I guess also that we should treat them differently. Because overuse injuries in kids and adolescents, they happen more and more, maybe. They have demanding day-to-day activities. We, as parents, we want them to be exhausted after training, so they fall asleep at night. But we do not want them to fall asleep while they're doing the schoolwork, because they have to do both. So I would say that for many adolescents, at least, they have a lot more stressful day-to-day activity than professional athletes, because professional athletes, they have time to rest, they can do PlayStation for quite a while every day, while adolescents, they have to do everything. They're training, and they're also going to perform in school. And as part of this, I would recommend that you read this editorial from the British Journal of Sports Medicine from Professor Roald Barr from May last year, which is called The Demise of the Fittest. Are we destroying our biggest talents? His points being that we put too much pressure on them, they train too much, and with I'm saying that maybe as a parent and also as a coach. I usually use this model in the clinic, in the patient room, when the patients are there, to trying to explain and get them to understand why they have anterior knee pain if they play basketball 6 times a week and 2 or 3 matches every weekend. So the envelope of load acceptance, if you load, the red circle is within the envelope, then you have no pain. But then when you're an adolescent and you're growing and everything else is happening, we know that the envelope can shrink, so you can still have the same load which was normal before, but now it's too much for what your body can handle. And there might be a lot of reasons, but when we're talking about adolescents, the growth spurt always comes up as a point where many of them develop their problems. And when we see adolescents with anterior knee pain, there are a few diagnoses that are most common. I would say that these are the ones I see most often. Larsen disease, or Osgood-Schlatter disease, patellofemoral pain, and patellar instability. And we also see some tendinopathies, but they are rare in the youngsters. And then as physiotherapists, we also have to remember that there may be other conditions that can give kids anterior knee pain. So be aware of the red flags if they have pain at night. And if you start a good, adequate rehabilitation program and the knee isn't responding as you expected, think that there might be something else. could be a cartilage injury, could be an osteosarcoma, and it could be rheumatoid illness as well. But if we look away from the bottom ones there, I would say that the treatment for the most common anterior knee pain overuse injuries in children is that it's usually overload of the soft tissues or the growth zones, and the treatment should be to adjust the load. So morbus Sinding-Larsen, I've put this up because I've had a lot of second opinion patients coming in over the past couple of years, where they've had this neovascularization, started eccentric training and had radial shockwave therapy because they've been treated for a jumper's knee, which actually wasn't a jumper's knee. They have a Sinding-Larsen-Johansson disease, which is pain and overuse of the growth plate at patella. And that makes me think, is ultrasound as helpful as we think? I still haven't got an answer what the apex patella and the patella tendon looks like in a 13-year-old active kid. Maybe the neovascularization is normal in kids. So when we think rehab and returning these to sport, or keeping them in sport maybe, the main thing is to reduce the total load. I think this is one of our main assignments, to help them to stay social with their team, because if kids fall out of sport for a few weeks or a couple of months, it's a danger that they're not coming back. And to do that, it's important to bring the parents into the rehab. They have to do, I think, the exercises with the kids, and they have to be part of the decision making, which I'll show you how we structure. Because this is what kids and adults in sports is actually about. Probably no one of these will become elite athletes, and the most important thing is that they stay active and have fun. So we have this sort of rehab algorithm, or return to sport, or keep in sport algorithm maybe, for kids with anterior knee pain. The first thing for the basketball player who comes in is to review the training and match exposure of the past 6 months. And this is educational in a way for the girl, but mostly for the parents, and hopefully they bring it further on to the coach. We also review the weekly schedule. We think that we have to remove some unnecessary load. I'll come back to this a bit later. Try to learn them symptom coping strategies. We do some active rehab aimed at the impairments that we find in our evaluation. But one of the main points here is that this, for me at least, is down here. The most important thing here is not the rehab and the training, but it's getting them to get control of the loading up here. And the final part is then to give them a graded increase in exposure, so they're not coming back with recurrent problems. So regarding the reviewing of the training for the past 6 months, is there an increasing frequency? We see that quite a lot when 15-year-olds start in high school. They go to sports high schools, and they go from 4 or 5 training sessions per week in June, and then they have 12 sessions from August. And then in November, this time of year, they come in with pain. Is there an increase in intensity as they change their environment? Maybe, usually these are good players, so they maybe have been selected one year up to play with their teammates, which is 1 year older. Are they playing several teams? Mostly, yes. And I asked them, did you have any summer holiday this year? And many of them didn't. Because if you're a good 15-year-old basketball or handball player in Norway, then you play with your team and your school throughout the year. And then during summer holiday, you have all the championships. So then they go traveling in Europe, playing, and they play 12 months a year. I want them to review their weekly schedule, and they have to write it down on paper. That's sort of a home assignment from session number 1 to session number 2. Come back with your weekly schedule. And then we have to put in where do you get your rest, and which of these sessions can be removed. And I think it's a good thing that they are allowed to pick out those sessions themselves, and then we review it and see, okay, this looks fine. Let's try it out for a couple of weeks. And if they come back still with pain or more pain, then we have to reduce it a bit more. Remove the unnecessary load. And what's unnecessary, that's very up to each and every patient. Most of them play, if it's a football player, they play football in school as well, and maybe the parents, they're very eager, so they take them for runs on Sundays. So then we should remove those unnecessary loadings. Try to get them to change from running to cycling. Maybe decide school sessions or club sessions, at least only one each day, not twice a day, and look at their leisure time activities. Then we want to learn them how to cope with their problems. Sometimes it might be isometrics before training, could make them less painful when they're training. Want them to do rise after loadings, after every session, that they put ice on the knee when they come home. We use the pain monitoring model, which has been up here now a couple of times today. I put in rest days. They have to have at least one rest day a week. Try to encourage them to have less playing time. Play only one game every week and stay only with one team, at least for a while. Because most of you see in these patients, and when it's a successful player playing at several teams with knee pain, overuse injury, who is the coach? The father, usually. So it's a good thing to have him or the mother or into this, so they have to learn as well. Then we do the rehabilitation, which is, in most cases, it's not aimed at the knee, more for the hip. So we're trying to increase the size of the envelope, training them to absorb shocks with jumping. We can use different methods to take away the shock. And the strength sort of functional training is mostly aimed at the hip, the hamstring, and the kinetic chain control exercises. And then when we hopefully are able to stabilize them, sort of they're in a load where they have control of their symptoms. For many, that could be that they are allowed to play basketball Mondays and Thursdays in the beginning, and they can do cycling on Tuesdays and Fridays, and they can do strength training on Wednesdays, and they have to have the day off on Sunday. Try to find the load that they can cope with their symptoms, and then increase the loading either by increasing the frequency or the intensity, not both at once, and then continue with the coping strategies to have them hopefully with low symptoms in the future. And with that, I'll hand over the floor to Dr. Clarsen. Here you are.
Thank you. Is that going now? Yep, good. Thank you. Okay, so Norwegians aren't just good at cross-country skiing. I should start with that point, that we have some other sports as well that we have some success in. And my sport that I've worked most in for the past long time now is road cycling. And I'll give a case of an injury type that I've seen a lot of, especially amongst these talented young elite road cyclists. Now, in the very unlikely case that you recognize who this is, it's not him, but it's one of his teammates over the past few years. And it is a 19-year-old male cyclist. He was in the junior national team in the previous year before he presented, and then had recently signed for a semi-professional team. So first year in the senior ranks, where also his loading and training loads are increasing rapidly. He was a former cross-country skier, so he was relatively late to cycling, but with a huge capacity. And his training and competition loads have been increasing rapidly over the past couple of years. He trains, quite typically for cyclists, he trains with a local club that have an elite program that try and train together most days. So there's relatively little individualization for him, except he adjusts a little bit by feel. But up until the point where he joined the semi-professional team, he didn't really have access to a individualized, personalized coach. Now, the case is a rapid onset of right anterior knee pain. It occurred over the course of one day on a winter training camp. And he'd recently changed, so new team, new bike, and new shoes. And so for him, relating back to my presentation earlier today, he blamed it on this change. Okay, he came into me, I've changed shoes, changed bike, and this is why I've got this knee pain. And his current status is that he can manage up to 30 minutes of normal, easy cycling, but then he gets an onset of pain which increases over time to the point where he can't continue at around about 1 hour. But also quite typically for this presentation in this group is that he can do everything else. So it's not the classic patellofemoral patient. He can sit still, there's no cinema sign, he can go up and down stairs, he can jump, he can lift weights, he can run, no problems. But put him on a bike, after half an hour, he's got pain every time. And in the clinic, in a basic examination, was nothing to find, okay? Not able to reproduce his symptoms, none of it normal testing was giving us anything, and his imaging found nothing. Put him on a bike, and after 30 minutes, we could start to palpate something on his medial patellofemoral border, quite high up, but still very vague. And also his biomechanical assessment, there wasn't much there. So he moves very nicely. He has great clinical biomechanics, looking at his bike position and his cycling technique. Also, unfortunately, in a way, in a clinical context that we have things we can work on, he was very, very good. So we always have an acceptable range in bike position. You look at a professional peloton, it's not that everyone rides exactly the same, but there is a normal variation, and he was well within that. So what's his diagnosis? I guess most of us out here have some kind of idea, some kind of first impression of what the diagnosis is, but at the end of the day, does it really matter? Because we're going to treat him in the same way. So the big question, do we remove from play? So back to my presentation from before, the removal from play decision making, and we're going to apply this START framework. Okay, so firstly, the assessment of the health risk. Now, this is a relatively benign condition, okay? It's not going to threaten his life or his long-term function, we don't think. But in my experience, this is something that really does have a tendency to become recurrent and can really stop career development. It can be a major problem for them. What about the activity risk? Well, obviously, as a high-level road cyclist, he needs to be able to perform for 4 to 5 hours every day, day in, day out. On this semi-professional level, the tours last up to 10 days in a row. So very high demands here. And in cycling, it's really not possible to accept that you're going to perform with, or participate with reduced performance. Okay, you have to be at your best to be able to compete. And another challenge is we have relatively little opportunity to protect the injury. So we can play around with these bike position and bike fit parameters, but really the loads going through the extensor chain are very, very hard to change substantially. What about the risk tolerance modifiers? Well, this athlete, he's young, he's keen, he feels a lot of pressure to be participating in this new team he's just signed for. And he's really upset because he's done a lot of hard work to get to this team, to get to this level, and he feels that his hard work is going out the door. A lot of pressure from his side to continue to participate. But it's a good time of the year, okay? This is in February when it happened, so it's a long time until the major season goals. And luckily, there's very little pressure from the team. So he has a great manager who's been through this many times before, and he's understanding and the guarantee that he will still be paid the very small salary that these young riders get. So at least from that perspective, it's good. So okay, I think our removal from play decision is quite obvious here. It's not possible for him to continue in any meaningful way. We have to really substantially reduce his loading. We don't need to do it completely, so we're going to use this pain monitoring model that Karen has first published and described. But in my experience, with this type of injury, we can't go all the way up to 5. We don't have the same clinical progression if we allow that much pain. So for me, I'm still in with this particular patient telling him to stay lower, down in the safe zone. A little bit of pain, 0 to 2 is okay, but don't let, and especially if it's increasing, we need to stop. And also, purely based on my experience here with these type of patients, that I will give him an estimated return to play of 6 months, which is obviously a very long time, but it's better for me in this perspective, I think, to be a bit more conservative and give him an expectation of 6 months, so that if we get him back quicker than that, that's a bonus, rather than saying, let's test it out in a few weeks' time and being a little bit vague with that communication. Okay, so this clinical model that I presented before, we have an athlete presenting with an overuse injury. The first thing is to reduce the load. We then want to address his risk factors. So as I said, there was very little to look at with his bike position, but it's still possible to try and change something, change the loading, see if we can influence it, lift his saddle height a little bit, which should theoretically reduce the stresses going through the patellofemoral joint. But unfortunately, in this case, we didn't have a substantial change in symptoms. And in this regard, I think we need to look at it like Bill Vincenzino talks about manual therapies, that we need to have a treatment direction test. So if there's a big change in symptoms, and in this case, it would be the time taken for the symptom onset, then it's a positive change and we can go with it. But if we don't have any really big change in the symptoms, then it's not likely to be a significant factor. Increasing his load tolerance. So I think we need to put him on a heavy resistance training program with the theoretical idea of increasing his load tolerance over time. This would be just a progressive standard lower limb resistance training. And then maintain his fitness. So luckily in this case, he can do everything else. Okay, so he can, being an ex-cross-country skier, he was very happy to get the skis back on. In the summertime, he was doing roller skiing as well as swimming. And then in the model, it looks like this. So we go through these early phases and then try and replicate the sport-specific demands. But of course, it's not really like this, is it? It's more like this. So we want to gradually reintroduce the sport-specific demands to the point where we're confident that they can return to play. And then, with coordination with the coach, we want to then get him back into a well-structured program. So this is our goal here with him. How did we do that concrete? We invited the coach and the athlete to a meeting at the beginning, so early in the rehabilitation process, and discussed which factors can we manipulate. Okay? We have the frequency of cycling training, the intensity, the duration, and the type. So we can look at indoor cycling compared to outdoor cycling and flat compared to hills. The other forms of endurance training he's doing, as well as his resistance training loading. So all this goes into the conversation, and then we ask the coach, well, what are your priorities? Okay, we can manipulate these and we need to systematically, gradually increase these over time. What do you think is most important so that he's best when he's back? The coach said long duration training first. That's a priority. Then he needs to get up to at least moderate intensity training. Then high frequency, then high intensity. So the plan. Okay, we kept him, as I said before, in this safe zone, 0 to 2 from a pain model. We started on the indoor trainer and then moved into local circuits. So the point here is that if he gets pain, if he gets over 2 on an indoor trainer, he can just stop. If he's cycled out half an hour away from home and he gets pain, then he has to get home. So from the indoor trainer, we start doing small circles, okay, 15-minute laps, so he's never more than 8 minutes away from home. And then we gradually increase the size of that loop over time and increase hills. His resistance training should be high intensity but low volume, so he recovers quickly, performed twice a week. And this is following some protocols that were also developed up in Lillehammer by a guy called Bent Rønnestad that has really done a lot of research into the performance effects of heavy strength training in cycling. And his off days can be spent performing any type of alternative endurance training as long as he doesn't have symptoms. We then created a plan that looked like this based on those coach priorities, so where we gradually increased the duration, then the intensity to moderate intensity, then the frequency, and then the high intensity. So we started with a structured plan. And the idea is that the athlete can progress. There's a milestone for each step, and the athlete can progress through the plan once they've been able to repeat each step twice without pain. So the quickest that the athlete can actually get through this is 4 months. But if there's any kind of slower progression than expected, it may take longer. And the coach can, if these are concrete enough and well enough set up, then the coach can take control of this progression, not the physio. So that we are in constant contact and in telephone talks, but they become less and less because the coach is empowered to actually take this athlete themselves through the rehabilitation process. Okay, so once the athlete is back to full return to play, we need to avoid any large changes in loading parameters and only increase one at a time. Remembering that the changes in these intrinsic and extrinsic risk factors do change our tolerance to load. So if we're going to be right on the edge of our tolerance, then a change in bike position or in bike equipment can push us over into an injury situation. So before they change the bike, before they change the shoes or the pedals, they need to drop back on the load and then continue a lower load and build up again after they've made that change. And then take extreme care at these high loading periods. And for us up in Scandinavia, these winter training camps where they finally get down to the sun somewhere in southern Europe and they're just going crazy training through the roof, this is a really, really dangerous time, as well as at the start of the season when they go from controlled loading to an uncontrolled situation in a race. Okay, well, I think we're back to you, mate. Or shall I just take it? Okay, well, take-home messages with respect to return to play. We want to assess and tweak the total load, include parents or coaches. Remove from play may be necessary. We need to apply the model or think in the same way that we think of with return to play, we need to think of with removal from play. And we need to have a structured progression through a plan, ideally where all parties concerned, so players, coaches and therapists or medical team are involved in the structuring of that plan. Thanks very much.